Hi all, and welcome to our Monday Talks live talk. Today, I'm going to be talking all about small intestinal bacterial overgrowth, or SIBO for short. And okay, there we go. Now we're live. Just in case that didn't go through, welcome to Monday's live talk this evening. Today, I'm going to be talking about small intestinal bacterial overgrowth, or SIBO for short. So anybody listening, if you struggle with digestive issues like IBS, constipation, diarrhea, bloating, like this almost pregnant style of bloating, possibly very foul smelling gas or GI pain, then you'll definitely want to listen to today's talk. So IBS affects roughly 10 to 15% of the population. And because I specialize in digestive disorders and chronic health conditions, it makes up a much larger percentage of my practice. In fact, it was bowel issues, it was irritable bowel syndrome that got me into this field. So I'm very familiar with it. I'm both working with it as a practitioner and then also struggling with it as a client. So it's estimated around between 50 to 70%, depending on what study you read, of IBS is directly related to what is called small intestinal bacterial overgrowth, or SIBO for short. So before I get into, actually, I'll share. SIBO, just as the name implies, SIBO is an overgrowth of bacteria within the small intestines. Now, normally we have trillions of bacteria that live in the colon, in the large intestine. And these bacteria are so metabolically active and so important to our overall health and well-being that some researchers are starting to classify them almost as another organ system. We have bacteria everywhere, on our skin and our mouth. They influence our health. There's more bacterial cells than there are human cells. So DNA specifically, more bacterial DNA than there is human DNA. So really and truly, they're hosting us more than we're hosting them, right? Now, I mentioned that there's trillions of bacteria in the large intestines. In the small intestine, there's, maybe a few thousand, relatively speaking. There's really not supposed to be that many bacteria in the small intestines. Now, through several different mechanisms, which I'll describe in a minute, what can happen is these bacteria both translocate from the colon to the small intestines, and bacteria that were already in the small intestines also begin to proliferate and create a dysbiotic state called SIBO, or bacterial overgrowth. So let's talk about first what normal intestinal function looks like and the normal microbiome looks like, and then I'll talk about some of the mechanisms of SIBO. So in a normal digestive tract, the intestines are basically one long skin tube that just runs from one end down to the other. And it's the closest that the outside world comes in contact with our inside world. So because of that, we have about 70 to 80% of our immune system within the intestines. We see this in Peyer's patches. We see this in the gut-associated lymphoid tissue, or GALT. So nonetheless, the other factor to our immune presence is found in two ways. One is hydrochloric acid in the stomach. We need sufficient hydrochloric acid not only for digestion and absorption of food and nutrients, but it's also a protective mechanism. You can understand it by thinking, if we eat a food with bad bacteria, let's pray it's killed in a vat of acid before it's passed down to the rest of the intestinal tract, right? So that's one understanding, is the need for sufficient hydrochloric acid. And in a second, I'll talk about how acid reflux is actually most commonly a symptom of low hydrochloric acid rather than too much. So sufficient hydrochloric acid. The last kind of protective mechanism of the intestines that I'll mention is the intestinal lining itself. So the intestinal lining is one of our first and most important barrier systems. Barrier systems meaning the intestinal lining is supposed to be very tightly bound, meaning nothing can get through unless it is absorbed. But through the mechanisms we're about to talk about, that can degrade the integrity of the intestinal lining, and now Large undigested food proteins and bacterial byproducts are inappropriately allowed to leak through into the rest of the blood, which then stimulates an immune response, and that's why it's estimated about 80% of disease arises in the intestines. So, continuing now with SIBO, understanding the mechanisms of SIBO. Normal digestion, we should be eating in a calm, relaxed state. We smell and anticipate food. All of that starts releasing digestive juices, hydrochloric acid, bile, pancreatic enzymes, so that when we eat the food, we thoroughly chew it, mix it with saliva, breaks down into smaller subparticles, hits the stomach that's coated with acid. That coating of acid, that release of acid, triggers the feedback mechanism to close the lower esophageal sphincter, the LES as it's called, which prevents acid from splashing back up or refluxing. When we don't release that acid adequately, that feedback mechanism never happens, which means the lower esophageal sphincter stays open, and therefore any stomach churning allows that acid, what's now called chyme, to splash back up into the esophagus. So that's a brief overview of why acid reflux is more commonly associated with too low of acid than too much. So nonetheless, food mixes with the acid, breaks down into smaller and smaller subparticles, passes on to the small intestines, triggers the release of bile and pancreatic enzymes, again through another feedback mechanism, further breaks down the food into tinier subparticles until it's absorbed through the 20 some odd feet of small intestines, and the remaining is passed on to the colon. That's what normal should look like. Now, if we start to break down, looking at, for example, stress. Now, keep in mind, when I say stress, I don't just mean like hair pulling out, like, oh my gosh, overwhelmed kind of stress, emotional stress, in other words. The body has one stress response mechanism. From a hormonal perspective, there's one stress response mechanism. So your body doesn't know the difference between having a deadline, sitting in traffic, having a sensitivity to a food, or having an infection. It's going to elicit the same response. Now, in our day and age, we're running from lions all day long, right? We are sitting in traffic, we're juggling family and career, we're juggling deadlines, we're juggling all of these things. And so we're often in that sympathetic state. But then also, when you look at like nutrient deficiencies and other forms of stressors, we can be in that state even if we're not consciously aware of it. Now, I walk through that because stress really paints a nice picture of what happens when that process, the digestive process, breaks down, right? What happens when we're, for example, not present with a meal, or if we're eating poorly, like poor, low quality food, nutrient void food, then what can start to happen is that now we sit down to eat, and sometimes we don't even sit down to eat, right? We're eating while we're driving, we're eating while we're working, we're eating while, chasing after kids, and we're not present with the meal. We don't release saliva, we don't thoroughly chew the food, and we don't adequately release hydrochloric acid. So now that food becomes partially broken down. We don't have the protective aspect of hydrochloric acid. And so now this weakly broken down food, potentially contaminated food, gets passed on to the small intestines. We get a weak stimulation and weak release of pancreatic enzymes and bile. And so again, that food is only partially broken down. And what loves partially broken down food is bacteria. And so these bacteria now start to feed on the food. And just like any species, the population is controlled by food availability. So if food scarcity is a thing, the population will only grow to the point that food can contribute to it. Support it. That's the word I'm looking for. Support it. So if this is repeatedly happening and we're repeatedly feeding these bacteria with poorly digested food, then it starts to lead to this overgrowth of bacteria. Now, here's the thing though that's interesting about SIBO. And what I mean by feed the bacteria is specifically fermentable sugars, fermentable fibers. That is what bacteria feed on. And when they ferment these sugars, fermentation inherently creates gases, in this case specifically hydrogen gas. And hydrogen gas, because it's in the small intestines, it gets trapped, and it also irritates the gut lining. And so it gets trapped, creating bloating, and then it irritates the gut lining, creating, along with the bacterial byproducts, creating GI inflammation. It also affects intestinal motility. So instead of this smooth peristaltic wave motion, we kind of have more spastic motions. And so the hydrogen, what's called hydrogen dominant small intestinal bacterial overgrowth, is more associated with a diarrhea presentation. Here's a part to SIBO that a lot of people don't understand though. With methane dominant, yes, it is possible to have an overproduction and overabundance of methanobacter and other methane producing bacteria, methanobacter being a family of bacteria. That's possible. So you can have bacteria that create, again, they ferment these sugars, they release methane gas as opposed to hydrogen, and now we have methane dominant SIBO. And what happens with methane dominant is it actually slows motility. So methane dominance is more so associated with constipation dominant IBS. There's also a mixed. And what can happen in the mixed is that we've got an overabundance of bacteria that are producing hydrogen. We also have another kind of microbe called archaea. Archaea, and it's ARCHEA. Archaea are a completely different species. They're not bacterial, they're not fungal, they're their own class. Archaea are some of the first organisms to ever have lived. You can find them in the most extremes of environment, from the Arctic to volcanoes. They're extremely hardy. And you can find them in our gut. They're actually one of the first things to populate the gut. And archaea eat hydrogen and produce methane. So it's possible, where I'm saying mixed, is you can have hydrogen dominance, methane dominance, or this mix. And what's happening with the mix is you've got a bacteria producing an overabundance of hydrogen from fermenting the sugars from the food that we eat. Archaea eat that hydrogen and produce methane. Okay, so that's where this mixed IBS constipation comes in. Generally speaking, with SIBO, bloating is a pretty common thing. So that's one of the dead giveaways. Another dead giveaway is if you take a probiotic and you feel worse, that can be a dead giveaway of SIBO. Now, conventionally speaking, the treatment is a course of antibiotics called Xifaxan or rifaximin. And for some, when you read the studies, rifaximin can help for sure. But what generally happens is it knocks it back. It knocks the bacterial levels back. It doesn't knock it all the way gone. And so then, because of the fact that a lot of those underlying mechanisms were never addressed, like the low hydrochloric acid, proper immune function, another really big one that plays into what I was just talking about with the stress response is gut-brain connection. So vagal tone. So we have the vagus nerve, the 10th cranial nerve that originates from the brainstem and innervates basically everything in the abdominal area. And it directly communicates with the enteric nervous system, or the gut brain, if you will, the intestinal brain. And that connection helps maintain proper intestinal motion, proper immune system status. We have sphincters in a few different areas, kind of dividing the stomach to the small intestine to large intestine to rectum. So we have these different sphincters that are supposed to be one-way valves. And with poor vagal tone, those sphincters start to become kind of like stretched out rubber bands. And so that's part of what allows bacterial translocation to occur too. So poor gut-brain connection and sympathetic overdrive, or chronic stress, in other words, along with everything else that we talked about with low hydrochloric acid, poor immune response in the gut, and then also poor pancreatic enzyme and bile output, all of these factors are at play when we're dealing with SIBO. So it's not as simple as kill the bacteria from an antibiotic, because if that bacteria still has food from our diet, from poor digestion, from stress, poor immune response, then it's just going to come right back as soon as we stop taking the antibiotic. So how to really, and I should say that's why SIBO is considered such a beast to kill and why there's such a high recurrence rate, is because those underlying mechanisms are not addressed. From an integrative perspective and a nutrition perspective, all of those are taken into account. So first, testing. How do we confirm if SIBO is happening or not? The gold standard right now, even though there are flaws with it, the gold standard is hydrogen breath testing, hydrogen and methane breath testing. So what that involves is you fast the day before, you can only eat certain foods. And then the next day, you, in a fasted state, drink the solution, and then you measure your breath. You blow into this device, you measure your breath over the course of 2 to 3 hours, depending on the test. And it will measure the amount of both hydrogen and methane gases. And if there's an increase, the graph looks like that. If there's an increase, then that would be SIBO positive. Like I said, though, there can be some false negatives. So we see this most commonly with people with diarrhea that have fast transit time, and that fast transit time skews the results. So instead, it's just a flat line. There's like no measured amount of the gases, and that's often kind of a giveaway that there might be a false negative. But nonetheless, so that, like I said, it's the most common. You can do a small intestinal aspirate test where they actually come in and scope the fluids that are in the small intestines, but as it sounds, it's a lot more invasive, which is why it's not as commonly done. Organic acid testing, which is a urine test, that can also give you an idea if there's elevated bacterial markers or sometimes fungal markers, because SIFO, small intestinal fungal overgrowth, is a thing also. So if there's elevated bacterial markers, then that's an indication coming from the small intestines that SIBO might be happening, and then you just combine that with what the person is presenting with too. And I know of 2 blood tests also that measure bacterial endotoxins that can be indicative of SIBO. So first we test, is this actually what's happening or not? Because there's plenty of other conditions that can create the same symptoms as SIBO. But like I said, 50 to 70% of IBS is associated with SIBO, so it makes sense to rule it in or rule it out. So test, if it comes back positive, then we start going down this pathway. So first, we'll work with diet. There is a diet, actually 2, specifically for SIBO. One is called the specific carbohydrate diet. The second is called FODMAPs, low FODMAPs. FODMAP is an acronym for those fermentable sugars. So FODMAP stands for fructo, oligo, disaccharides, mono, and polyols is what it stands for. And those are all the kinds of sugars that bacteria can ferment. So basically feeding them. And remember, if we feed them, they grow. So those can be effective. Those can be very effective. They're difficult diets. They're restrictive and limiting, and there's a lot of conflicting information. So I don't honestly always start with FODMAPs. I'll sometimes start with more of a paleo style of eating and test for food sensitivities, remove those, see how the person responds, move forward with an antimicrobial regimen, more of a broad spectrum antimicrobial regimen. And if the person's responding favorably within the first 10 to 14 days of that nutrition plan and antimicrobial regimen, then we'll stick with that. And we don't need to do FODMAPs. Others, we do. So others, we're not getting the movement that we need to. Literally, I guess. We're not getting the response that we need to. And so in those cases, I will transition them to FODMAPs for about 2 weeks. Follow a low FODMAP diet for about 2 weeks, complete the antimicrobial regimen, and then start to reintroduce FODMAP foods to see which ones are problematic and what quantities. So it's more of a temporary approach. All during this, couple things to mention. One, it's important to include biofilm disruptors. So this is another reason why traditional, just a round of antibiotics oftentimes won't do the trick, is because bacteria, much like parasites and funguses, can form what are called biofilms. And biofilms are these protective sheaths that microbes form over their colonies to protect them from the immune system and antibiotics. And so we need to disrupt those biofilms, and there are certain nutrients that we can use to do that, disrupt those biofilms so that the antimicrobials and our immune system can actually get in and be more effective. So that's one. The second is supporting all of those aspects of digestion as well as vagal gut-brain connection. So supporting hydrochloric acid, supporting enzymes, supporting different aspects of digestion. Sometimes we need prokinetics to help with motion. So there are different nutrients that we can use to help with motility. And then the gut-brain connection. And this is something I work a lot with within my practice, that there are specific exercises and tools that I will use so that we're not just kind of, they're forms of biofeedback essentially. So we're not just like playing around and, deep breathe, for example, even though I love breath work, not knocking that. That's actually a big part of it. But there's some forms of biofeedback and tools that we can use to help strengthen that mind, body, and gut-brain connection. So those are all of the factors to consider, then coming in with those antimicrobials simultaneously. There's kind of different phases to go through with that as well, so that we're eradicating the bugs and then creating an environment where your own body, your own immune system can prevent the recurrence long term. And then at that point, we continue forward and we can start looking at reintroducing food and going from there based on how the person is responding. But that basically encompasses SIBO in a nutshell. And a lot of people ask about SIBO. A lot of people ask about a low FODMAP diet. I actually, in my group, Integrative Health and Nutrition for Chronic Illness, just shared and I'll share it here too, a 7-day menu plan and prep guide for low FODMAP eating. It's all recipes and a 7-day menu plan, breakfast, lunch, dinner, snacks for low FODMAPs. Because like I said, it can be really confusing. There are certain sources out there that are more reputable than others. And I recommend picking one source and going with it and sticking with it, because otherwise you might find contradictory information. But nonetheless, I wanted to get on and share about SIBO because there's so many misunderstandings and kind of confusion around it. And because, like I said, it impacts 50 to 70% of IBS sufferers. So I hope that was helpful. It looks like several of you logged in, which is wonderful. Thank you all for joining. And if you are struggling with digestive issues, please do not hesitate to reach out. I can appreciate firsthand that digestive issues are so much more than just, my stomach's upset. It really impacts every aspect of your well-being and quality of life. So I'm here to share that you do not have to suffer. So if you or anyone else that your friends, loved ones are suffering with irritable bowel syndrome, please do not hesitate to reach out, and I'm happy to help. And otherwise, I hope this was helpful. For more information like this and to have access to that menu plan, please join the group, Integrative Health and Nutrition for Chronic Illness. Okay, thank you all so much. Stay tuned for next week, topic to be determined. As always, I'm taking requests. So if there's anything specifically that you would like me to cover, please let me know. Otherwise, I look forward to talking with you at a later time. See you next week. Thanks again. Bye.